Today we are going to speak about juvenile idiopathic arthritis. So this is a very peculiar condition because we might not be treating these kids, but these children who present to us with joint pains are basically going to come as they'll be seeking help for joint pain basically. Okay, but when it comes to diagnosis, classification, and treatment of these children, it is best done at the hands of a pediatric rheumatologist. Okay, so without delay, let's come to the important aspects of this. Joint pain is a common childhood complaint, and the orthopedic surgeon is often the first specialist to encounter the child with a joint pain, limb pain, or back pain. So, what we are going to do is we are going to understand what the problem is. So, about 1% of all children are evaluated for joint pain. Now, out of this 1%, 62% of these children are referred to an orthopedic surgeon for the evaluation of joint pain. Now, out of the rest of the 38% go to either, say, a general physician or a pediatrician or to a rheumatologist directly. Okay. Now, what is of importance is that even when we're talking about a pediatric rheumatologist, only about 33% of the cases that a pediatric rheumatologist sees, so about 1/3 of his or her practice, is a referred case from a orthopedic surgeon. Okay, so now the question is, where do the rest of the children go? Okay, so the rest of the children are generally either not diagnosed enough or they are not being treated enough for juvenile idiopathic arthritis. Now, the problem basically lies in understanding this complex syndrome. Okay, so juvenile arthritis is a term for persistent arthritis lasting more than 6 weeks of unclear etiology. Okay, now to diagnose or to call it juvenile idiopathic arthritis, we need a good and detailed history. We need a good physical examination. We need to do certain lab tests. We need to follow it up with imaging, which could be X-rays, MRIs, CT scans, and we need to follow these children up because it is not possible to call a child as juvenile idiopathic arthritis with a single instance. Okay, so we need to follow them up, and only then can we tag or label these children as juvenile idiopathic arthritis. Now, the confusion comes with the definition of JIA. Now, what is the definition of JIA? According to the American College of Rheumatologists and the European Union League Against Rheumatism, in the 1970s, they had different definitions. They used to call it either JRA or they used to call it juvenile chronic arthritis. Now, this led to a lot of confusion about what actually these children are suffering from. They had different diagnostic criteria and they had different classifications. So in 1993, all the confusion was, say, streamlined by the newer classification, which was given by the International League of Association of Rheumatologists. So this was given in 1993, and they divided them into 7 phenotypically distinct categories of disease. So that is about oligoarthritis, polyarthritis, which could either be rheumatoid factor positive or negative, systemic JIA, psoriatic arthritis, enthesitis-related arthritis, and undifferentiated arthritis. So we'll talk about all of these, about how to tag them as one of these conditions, and about the clinical features that we see in all of this. Now, with regards to the prevalence of these conditions, in India, we see that what is different compared to most other countries or most other continents is that the enthesitis-related arthritis is much more common compared to oligoarthritis. Now, in the rest of the world, oligoarthritis remains the most common form of juvenile idiopathic arthritis, but in India and Southeast Asia, enthesitis-related arthropathy is more commoner than oligoarthritis. Okay, so the incidence is about 8.5 to 30 per 100,000 children, and the most common form is oligoarticular, followed by rheumatoid factor negative polyarthritis. But this is applicable when we talk about the entire world. But when we talk about Southeast Asia and India in particular, enthesitis-related arthropathy is more common compared to the other conditions. Okay, so most of these conditions are more commoner in girls compared to boys, except for enthesitis related arthropathy. Now, genetics has a role to play, HLA has a role to play in all of these conditions. Now, talking about oligoarthritis, the definition of oligoarthritis is defined as arthritis at least of 6 weeks duration in fewer than 4 joints during the first 6 months of the disease. Okay, arthritis of at least 6 weeks duration in less than 4 joints during the first 6 months of the disease. Now, oligoarticular GIA is further subdivided into either persistent or extended. Persistent oligoarthritis means lesser than 4 joints have been involved even after 6 months of the disease onset. Whereas extended oligoarthritis means during the first 6 months it was less than 4 joints, but after the first 6 months the number of joints was more than 4. And persistent oligoarthritis has a better course or better prognosis compared to the extended, because extended goes on increasing. The number of joints goes on increasing after 6 months. Okay, now oligoarticular is the most frequent category of GIA and most children present before the age of 4 years, and it's more commoner in girls. The etiology is unknown, but HLA-A2 has a consistent association with oligoarticular GIA. Okay, and 70% of these children are positive for anti-nuclear antibodies, and if the child is positive for anti-nuclear antibodies, they have extra-articular symptoms such as uveitis, more commonly seen in these children. Okay, so approximately 50% of the children with oligoarticular GIA present with a single affected joint, most commonly the knee joint, followed by the ankles and the small joints of the hand. Okay, about 25% of these children have painless arthritis at presentation. That means they present with something else, maybe uveitis. Okay, now they generally have a mild and rheumatic course, and sometimes when they have a long-standing unilateral knee arthritis, this would often lead to synovitis, which would lead to overgrowth of the affected limb, which would lead to limb length discrepancy. About 5 to 10% of these children are affected in the temporomandibular joint arthritis, which would lead to micrognathia, malocclusion, and chewing difficulties. Okay, so chronic uveitis is the most common extra-articular complication, and it's more commoner in children who are having ANA positive oligoarticular GIA. Okay, now untreated uveitis may lead to some complications which may end up in blindness. Okay, and out of all GIA, oligoarticular arthritis has the highest likelihood of remission. That means they may get better if they are a persistent oligoarticular GIA. Now coming to polyarticular arthritis. Now polyarticular means it's more than 4. That means 5 or more joints during the first 6 months of the disease. Okay, so we have oligoarticular, which was 4 or less during the first 6 months of the disease, and we have polyarticular, which is 5 or more during the first 6 months of the disease. Now polyarticular is also divided into 2 types, which is either RF positive or RF negative. Now what do we mean by RF positive? RF positive means there should be the presence of IgM RF on at least 2 occasions, which is at least 3 months apart. Okay, it's not a single lab investigation, but it is at least 2 occasions which are at least 3 months apart of having IgM RF positive. Okay, now this is the second most frequent subtype of GIA, and RF negative can occur at any age, but there's a biphasic trend. It can either happen at the toddler years, where again girls are more commoner than boys in a category of 3:1, and there is a second peak around adolescence, where about prevalence is more among girls, and the ratio is about 9:1. Okay, now the interesting aspect is that RF positive polyarticular GIA occurring in an adolescent girl is almost indistinguishable from an adult rheumatoid arthritis. Okay, so etiology again is unknown. Polyarticular onset GIA is characterized by the insidious but occasionally acute onset of symmetric arthritis in 5 or more joints. Now both large joints as well as small joints can be involved. The cervical spine can be involved, and the TMJ can be involved. Okay, now remember, in RF negative, patients who are